Okay, good morning everyone. Thank you so much for joining us. Today we have a wonderful presenter, Saul, who's a senior sleep scientist at Gold Coast University Hospital. But before we start, can I ask if everyone can turn off their microphones whilst Saul's talking? So the presentation will go for probably about 45 minutes, I'm just guessing. And then after that, we may have some time for questions and answers. If not, it depends on whether Saul agrees that you can send me some questions and I can forward them to him for him to actually respond after the event. So again, thank you so much. It's a very exciting topic for me, and it impacts, as we know, breathing impacts everyone with MND. So I'll take it over to yourself. So thank you. Introduce yourself if you would like.
Hey everyone, so my name's Saul, so I'm one of the senior sleep scientists here at the Gold Coast University Hospital, so at Southport. Everyone can hear me okay?
Yep.
Excellent. All right. So straight up, I've found a mistake on my slide. It's that today's date is not May, so it's not a good start. I'm sorry. So I'll fix that up. But unfortunately, it's recorded now. But today is Thursday, the 20th of April, not Tuesday. So sorry about that. Okay. So this is the hospital I work at. So it's a tertiary hospital. It's quite a big one. So we have a sleep lab here, which I work in. It has 4 beds, and we run up to 5 nights a week, running 3 patients a night, which does involve motor neuron disease patients as well. All right. So firstly, I know most of you guys know about motor neuron disease, so I'll just give you a quick rundown of the different 4 subgroups. Okay, so we got the one that everyone sort of hears about is the ALS, or the amyotrophic lateral sclerosis. This is the one I mainly deal with breathing. Okay, so when the ALS starts affecting your rib muscles and all the muscles in the rib cage, that's when someone like myself gets involved and starts talking about masks and ventilators and stuff like that. Okay, so the second one there, the progressive muscular atrophy. So that's more of a lower motor neuron control. So if you can see down the bottom there, the spinal lower motor neurons, that's where it starts attacking. But that can turn into ALS, and that's where it starts affecting the rib cage, and I get involved. The progressive bulbar palsy, so that's the really aggressive one, the bad one. So that attacks the bulbar stem at the back of the brain. But that mainly affects saliva and talk and all that, but then that can turn into ALS. So if it goes into ALS, which starts affecting the rib cage and stuff, it's called bulbar onset ALS. So these subgroups can change all around. So it's so I deal with all types of these. The one down the bottom is a primary lateral sclerosis. That's the rarest one of all, probably the one that everyone wants, because your lifespan is basically the same as someone without the disease, but it does affect your upper motor neurons in the brain. So it definitely affects you, but it won't kill you. But the top 3 is mainly what I deal with. Okay. So the things that we will look for is respiratory weakness. Okay, so things to look for is shortness of breath, fatigue, impaired quality of life, and somnolence. So somnolence is just a fancy word for tired during the day. Okay, so very tired. Dyspnea is a fancy word that we use in the hospital for shortness of breath. This is caused by weakened respiratory muscles that's usually attacked by the motor neuron disease. The first muscles that this disease attacks in the respiratory system is the intercostals, the diaphragm, and abdominal muscles. Okay. So to give you a nice little diagram here, so when you can see the diaphragm is pulling down, that's it drawing air in. Okay, so when the muscles attack that diaphragm, the diaphragm struggles to get the air in, all right? So once your muscles are struggling to get the air in, we have this phenomenon called underbreathing with motor neuron disease. So you're just not getting enough air in, so therefore you're not getting carbon dioxide out of the body either, all right? So once the motor neuron disease starts attacking these three main areas, the body realizes that you're underbreathing, that you're not getting oxygen in like you should. And what it starts doing, it starts using other type of muscles. So you'll start using intercostal muscles around the chest, especially inspiratory muscles in the throat. So if you see a loved one or someone with motor neuron disease breathing with muscles in their neck, usually means their muscles in the main areas of their respiratory system are failing. Right? So that's a pretty good sign there for someone, going into respiratory failure, they call it. Right, so the diagnosis and management of respiratory insufficiency is critical because most deaths from MND are due to respiratory failure. So it's that's why I'm heavily involved with end-of-life care and stuff, because what I do is I stop that from happening with a ventilator, basically, and I extend lifespans. Hyperventilation is the main thing, is my specialty, okay? So, and it is the major cause of respiratory failure. So hyperventilation is a technical term, which I'll get into a little bit after this slide, but some of the symptoms of hyperventilation, all right? So you'll have breathlessness, orthopnea, fancy word for lying flat and you can't breathe, all right? So this is a huge symptom for me to know that you need a ventilator. So if you go lie flat on a bed and you're like feeling like you're suffocating, that is orthopnea, and it's an early sign of MND, right? So that tells me straight away that something's going on with the respiratory system and gravity, all right? Morning headaches is one that I tell my patients a lot. So if you wake up every morning with a morning headache, it can be increased carbon dioxide levels in your body, leading to respiratory failure. So even on a ventilator, this is one of the signs I get my patients to ring me. If they're on a ventilator and they start getting morning headaches every morning, they'll ring me up and I'll tune their ventilator and try and get rid of these headaches. Most times I get rid of them the next morning, and straight away I know that it's doing a job, all right? If I can't get rid of these morning headaches, then we need medical examination, maybe more investigations type thing. Another thing that patients report is fatigue, and that's all due to carbon dioxide levels getting high in the body. Recurrent chest infections is another one, that some muscle weakness is happening in the chest where you can't get up your mucus and manage it properly, therefore you get chest infections. You get disturbed sleep, non-refreshing sleep, nightmares. So those three sleep things are more concerned with dyspnea or that shortness of breath. That's one of the main reasons why you'd have that. But the dyspnea will give us an indication to go investigate for respiratory failure. Daytime sleepiness. And then the last three is more getting into more of the type 2 respiratory failure event. So you'll start experiencing poor concentration and memory problems, confusion, hallucinations, and next step will be non-responsive. So the hallucinations, for example, I had a patient that hallucinated dancing potatoes on the roof right before they went to full-blown respiratory failure and stuff. So just if another patient had some weird feeling behind her eye, she knew that was happening. So everyone's different. It's a pretty scary symptom to have, but unfortunately, it's very common with MND. It's a terrible disease. You know. So some of the signs, so this is more for the medical, if anyone's got medical background, this is what I would look for in a clinic. So increased respiratory rate, which means you breathing faster. Right, so I can time your breaths. I know what the normal breath rate should be, and I can actually pick it up by sight. The doctors will do all this beforehand as well. Shallow breathing, that's the underbreathing I was talking about before. So if you feel you're not getting big, deep breaths, I should be able to see that, and I can sort of see with the mouth and all that. Weak cough, I'll probably ask you about that, and some of my patients give me a big cough and prove it to me. That will then lead me on to you need to go see a physio for a cough cyst and stuff like that. Weak sniff means you really sniff and you really get a big breath in. That's another sign. So if you have a weak sniff, abdominal paradox. This is something I definitely don't expect you guys to know about, but it's something I can pick up with the diaphragm and abdomen. So in theory, both your abdomen and your diaphragm should go up and down at the same time. This abdominal paradox is going opposites. So one's going up, one's going down. And the medical professional will be able to spot that on the spot. So if you get some doctor or someone like myself put my hand on your diaphragm, this is all the stuff we're sort of looking for, checking the timing and all that sort of stuff. Use of accessory muscles of respiration. So that's what I was talking about with the neck muscles before. Okay, so and another one's reduced chest expansion on maximal inspiration. So in basics, if you just can't fill your chest up like you normally used to, and you don't see much of an expansion of your chest, but this is all stuff that we can pick up in clinic. So, but the main things I'd like you to take away is that breathlessness, orthopnea, so lying flat, can't breathe, morning headaches, right? So that's my main three that I go for. Okay. So once you experience these things, it should be a good plan to go to a respiratory sleep physician and get into a sleep or respiratory clinic. All right. So the first thing that the respiratory or sleep doctor will do is send you to a respiratory lab, and they'll get a baseline measurement. So I find this very important. Even to get a baseline measurement, you should be pretty well. So the quicker you get into these guys, the better. So then we can get this baseline measurement. So lung function. So what we're doing there is working out the percentage of how much the lung is still working. So if you get in early, you might have a full 98% lung function, which is great. And then next time you come, you might be at 95, and then 92. And once this keeps dropping lower and lower, it gives us an indication of how much you need a ventilator. And it sort of gives us an indication of how quick you're going to go into respiratory failure. The problem with these tests is the sicker the MND patient gets, they're inaccurate, because unfortunately with all the muscles weakness and stuff, you just can't perform these tests that well. So it's good to get a little baseline measurement at the start. So they'll do pulmonary function tests, which is just a fancy word for lung function, basically. Spirometry, like you blow into a couple tubes and balls roll up and down. And this arterial blood gas is a very important tool of mine that I use. It's a nasty little needle. There's a picture of it down the bottom of the slide there. So the ABG stands for arterial blood gas. So what I need to get the gold standard of your blood measurement with oxygen levels and carbon dioxide levels is to puncture an artery and draw blood from it. So with the arterial blood, that means it's hit before all the lungs and it's not venous. So we get really good carbon dioxide level measurements with this type of test. That will tell me if you're going to type 2 respiratory failure as well. So the other thing is the lung function results can affect later procedures like feeding tubes, PEG and rigs is what they might call them, because of the anaesthesia risks. So at Gold Coast, our percentage of lung function used to be around 70%. If it was under 70%, they refused to do it. That in time, they've started to get quite good here at this hospital. Now that 70% starting to drop to lower areas, and I've seen them do some of these feeding tube operations or surgeries on really sick MND patients now, and they're successful. So PEG's usually when you've got a higher percentage of lung function. RIG's done when you got a lower one, and it's more radiography guided RIG. So, but that's more out of that's more into other sort of areas. But I'll just that's mention that we all sort of work together with these tests, and everyone uses each other's data and stuff. Okay, so the other thing it does, the arterial blood gas, it also measures blood acid levels. So when patients go into respiratory failure, their kidneys and stuff start trying to compensate for all the abnormal gases in the body. So, and those blood acid levels tell us how long, if you've been in respiratory failure for, mild, or is it acute, chronic, all this sort of stuff we get from them. So this is quite an important little measurement. But when you go see these guys, like that might be it for you for a while. You know, if everything comes back good, at least you're in the system and you just get reviewed every now and again by a respiratory or sleep doctor. Once these levels get a little bit worse, then they might start talking other interventions for you. And a lot of questions I get is because they'll next start talking about your sleep. Once you start getting worse, they'll start asking sleep and start asking you to go to a sleep study, and you're probably wondering like why. Like, you know, I've lived all my life, I haven't had a sleep study. My sleep, I've lived, you know, why would I muck around my sleep right when I've been diagnosed with motor neuron disease? And the main question here is for this REM hyperventilation. So this is a very simple portrayal of what we do in a sleep study. And so on a sleep study, you can imagine probably 4 times that much channels all up and down the screen. So this is just a very simple diagram just to show you why sleep is involved here. So REM hyperventilation happens only in REM sleep. So REM sleep is rapid eye movement sleep. It's one of the most known sleep stages, as it's your dream state sleep. It's where you sleep, you dream, and you basically your body turns into paraplegic with some working organs going, getting you really deep sleep, refreshing state for the next day. Right, so, and unfortunately with people with motor neuron disease and other states, like anything with muscle weakness in the diaphragm, we see this really bad thing happen here where your oxygen levels drop considerably and your carbon dioxide levels increase up. And this is a full hyperventilation syndrome here. So the good thing is once you come out of REM, you will go back to normal oxygen and carbon dioxide levels. But if you do this, so a REM happens at least 3 times a night. So the REM cycles are 90 to 120 minutes per night. So every 90 to 120 minutes, you should hit your REM sleep and then keep going until you wake up. People on average 3 times a night. So if you do this 3 times a night, that bottom baseline there with the carbon dioxide levels increases up a tiny bit each day, each night. And it keeps rising to a point where you're going to start feeling the symptoms that we were talking about before. All right, and you're going to go to your loved one, your partner, that something's wrong. I'm not breathing right here. And then they take you into hospital. And then, unfortunately, if your CO2 levels get too high, the only treatment there is ventilate you for 3 to 4 days, 24 hours straight. And you'll drive that carbon dioxide level baseline back down to normal, and then you'll be back to normal. But to stop this from happening every night again, because you'll be right for another month or so, it depends on the disease state. The way to fix this is wearing one of these things. So this is a mask and a ventilator. This is a very common setup that I do for life support. So this is like I've seen this in so many homes that I've set up hospital wide. This is someone on life support right here. So when I talk about life support, I don't want you getting scared with tubes and all this stuff and like an ICU type setup. This is all it is. But the problem, if you're on this sort of setup, you probably can't get off that mask. So you're on it 24 hours a day. You might be able to come off 5-10 minutes at the end, or 15. It depends on how bad it is. But we all have backup masks for you, so you can quickly change mask while you clean the other one. But that's how bad it can get, okay? And that's the path that some people choose. But so I'll get into the masks out there. So there's heaps of different masks. So the one I like to go for is the one that just goes over the nose. And the other cool bit that they're doing now is, I don't know if you can see those little clips, but they're magnets. So now there's no real fine motor control needed to get these masks off. So one of my techniques is I slide the fingers up to the mask and slip it off, and those magnets come straight off, and you can rip the mask off if you want. You know, one of the things I find with motor neuron disease is once the limbs start going, they can't take the mask on and off, and they lose their independence. Where with the magnets, I can keep that independence going a little bit longer, because you won't need the fine motor control to unclip and do all this sort of business. But unfortunately, it will turn into someone will need to help you if you really go down this path of the 24-hour ventilation. Okay. So the one on the left there, that's a full face mask. So the one that goes, you can see it goes over the nose and the mouth. And that's for people who mouth breathe quite heavily. So if I'm ventilating through the nostrils, that air is just going to come straight out the mouth, all right, if you've got a wide open mouth all night. Where I can add little chin straps on to hold the mouth shut, or we just go to this full face mask, and it's a lot more invasive on the face. But some people, some of my MNDs love it. That once they try that full face mask, they don't go back. They won't go back to the nasal. I've got others that live by the nasal. They won't go off any other mask. Okay, so I'm very patient orientated. So whatever you guys want, I'll just make it work. Okay. So this is one of my favorite setups here. Is just a little nasal mask. So you can see the magnet clips on the side. It's less invasive. Yeah, it's very nice. But one of the problems I do deal with is drool and saliva with these masks, because sometimes it does push saliva out the mouth and cause some issues there. But everyone's different. I would always try this mask first, and if it doesn't work, then go on to other types. So if you go to the right service, you should have a multitude of masks to choose from. I've got multiple companies in this storeroom here that I've all the different models all through the series, and we try and keep as much parts as possible. Just have options open, because I find with motor neuron disease, if you can get this all beautiful and fine right at the start, it makes the journey so much easier. If you do a dodgy start and just any mask, flick it on, you guys are going to have a bad experience, and you're not going to be compliant on the machine or use it, and it's just not a good outcome. So I can sometimes spend 2 hours finding a right mask for one of my patients, and I can go through maybe 9 to 12 if needed, just to get it right. There's this new hybrid mask that's coming out at the moment. I thought I'd show you this, because back to that life support type scenario, 24-hour day wearing a mask, we're making these masks now that don't cover the nose anymore, and it's still a full face mask. So you can see the man down the bottom, he's got it straight on his nostrils, where the man in the top right, he has it not off his nostrils. So, and it's all related to pressure injuries. So the mask down the bottom, I get a lot of pressure injuries on the nose. I've seen bone, through the flesh before. That's how bad it can get with these things. So then there's all these different type of paddings and stuff we can use. There's heaps of scenarios we can do, but I find this hybrid mask, if it works, it saves me all this trouble with the pressure injuries on the nose. Unfortunately, I'm now getting pressure injuries on the inside of the nostrils, but it's not as bad as the nose. Okay. And the type of machines that we set these masks up to, all right, so these are 3 examples that we use in our service here. And I've got a little spiel with them. So the difference between these machines is someone like myself picking, so the first one we go with is that little one in the middle. So it's a nocturnal ventilator. It's designed for 8 to 12 hours per night. This is what I start most of my patients on, just this nice little machine. Doesn't alarm, it works beautiful, has water in it. But and it also has a remote modem, they call it AirView, where I can log in from my computer in the hospital here and look at all the data each night. So I can then ring you up, like you could ring me up and say, I had problems the last 3 nights. I could look into the machine, look at all the data, and I'll say, oh, this is what's happening, and we'll fix it. It might be lower tidal volumes or something, so I'll increase pressures. So it's quite a good machine to do that. The only problem is it's not battery operated, and once you need more than 12 hours or 14, these things are known to potentially overheat. So that's where the different machines come into it. Some of my patients never want to go more than 12 hours a night, and they're just happy with just using it just 9 hours a day and just do it that way, which I'm fine with. Like it's always your path, and I'll choose with you. If we do start getting over the 12, 14 hour mark, we'll start thinking about upgrading you to a different ventilator. So the one on the right there, the night and day one, that one's, I feel that one's really good for people who need about 18 hours a day, but it can definitely cover the range between the early machine and that life support machine at the end. This one's quite nice, less alarms, but it does have a battery backup. So if without power, you'll still get about 6 hours of power with that one. So it's a nice little safe one to have as well. It'll give you 6 hours to get something sorted, at least if you have a power outage. It can do the same settings and timing as all the others. And then we get onto this one on the left. So this is the life support. This is one of the hardest machines to get because they're so expensive. But we've got a little stock of them here that we give to our patients and stuff, and I try and get funding. MND and other organisations donate to us and stuff, and so we always try and have these machines. So these ones are life support machines, and the reason I go for life support machines is these things are designed to go, that one there on the screen is designed to go 24 hours a day for 4 years straight. It's been rigorously tested. It's got 2 batteries in it. So it's got a detachable battery and an internal battery. So the detachable battery you can replace on the spot, and that does about 5 to 6 hours each time. So very useful for going outside. So just so you do get into that 24-hour ventilation scenario and you want to go outside, this thing will take you outside. I hook it into the wheelchair and we can ventilate you, and you can run nearly 12 hours without it. If you have spare batteries, you can put in more, but it just gives you that option of getting out of the house as well. So these things are pretty expensive. So you're looking at over 20 grand in the mid-20s for that life support machine. The one in the middle is more around the 5 to 7 you can sort of get them these days. The one on the right's probably getting to the 10 area, 10 to 12, but they're all different, on different sales. But the problem is with my setup at the hospital is if you need one of those life support machines, you need 2. Because what happens if you have a blackout and that blackout causes a fuse to blow in your ventilator, and you're gone, you're stuffed. So we usually give out 2 of these things. So you have one charged in the side of the room, and if this one malfunctions in the middle of the night, you go straight in the other one, like it's fully charged and ready to go. All right. So now you're looking at over 40 grand each patient. That's where my problems come. But yeah, that's my problem to sort. I always have machines. All right. So some of these interventions that I found. So one of the big interventions is non-invasive ventilation, is what I'm talking about. The masker machine, good nutrition, and multidisciplinary care. These all have been shown to help people living with MND to live longer. Right? So these are things you can choose. You're not forced upon these things. So the non-invasive masks, I've had lots of patients refuse it, don't want it, and that's fine. I'm happy with that. Like it's always your choice. So others want to go, but they don't want to go 24 hours. They just want to go 8 hours a day, and that's how they want to go, and that's fine as well. Others, usually younger, with a lot of family, they want to usually go the whole hog. They're ready to go right to the end, ventilate to the end. So. And to multidisciplinary care, I just want to expand a bit more on that because I feel it's quite very important to have a lot of disciplines involved in your treatment. So one of the things I've started up here is a multidisciplinary team clinic, which is run. So I have a doctor involved, a sleep doctor, physio. I've got a nurse practitioner. I have even the nurses that do PEGs. I get them involved in my clinics if needed. It's sort of my patients will tell me what they want in it, and I'll sort of coordinate the clinic, and it's like a one-stop shop. So I know there's other hospitals that do this as well. So PA in Brisbane also do a similar setup. They have a full MND clinic run by doctors there. So it is really good if your service is in your postcode, it does something like this. Yeah, I'd try and get involved in part of it, because it's one thing, it stops you coming multiple days to hospital. You can try and hit it all in one hit. So, because it's quite a big deal to get to hospital when you got MND. So I try and get back, buck for the value. And so, unfortunately, sometimes I've had to admit straight to the hospital, with some of the, so they come with something else wrong. I'll get, one time I even had surgical involved in my MDT, and yeah, got shot off for straight into the ward and had a surgery, stayed here for a couple of days and went home. So it can be, it can be useful. Right. The other thing is with the multidisciplinary care is also inpatient units. So the wards, if they definitely are better if they're well trained on NIV. So something I've been doing here is working with our respiratory ward and the nurses and training them on these home ventilators. So if you do bring in your home ventilator that's perfectly fine-tuned by myself, you get, sometimes my patients get put on hospital ventilators with incorrect settings and they hate it, they refuse it, they just yell for me to get them on this other machine, just put them back on their old machine, So the more training I do, so I've trained ED, a lot of them now will just go straight to my machine that they've come in with. And it all depends on how bad these guys are and stuff. But it's all about education. The respiratory ward here is very well trained in ventilation now, and yeah, very nice. I've got a lot of good feedback from my patients coming into the hospital here in our respiratory ward. So yeah. So, and this is the other thing as I was talking before. So non-invasive ventilation, this mask machine is a choice, right? So even if you start this thing and you've told everyone, I want to go 24 hours right to the end, at any point in time, you can stop that. You can take the mask off. You're not going to be forced upon this mask. You can, like, if you go unresponsive and you're on a ventilator, you probably will get put back on it unless you have directives not to. But yeah, it's always a choice. Okay, so I don't want people feel pressured into using the mask machine. I find I have the best results when I talk to my patients face to face and say, this is your call, this is your path, so whatever you want to do, you're in control here. All right, so unfortunately, when the voice goes with Bulba, I find people don't actually communicate to the patient and start talking over them and all that, where I'll stop that, and I find it very important to be able to communicate to the patient. Right? So if you do come to see me, I'll be expecting communication through notes or however blinks, but I will be getting to the point and getting some serious answers out of you, no matter what state. All right, so there is a path here where people don't use the ventilator and don't want to wear a mask, and that's fine. All right, so some of these conservative measurements here is what I go through with these guys. So your positioning in a chair can help. Sitting in a recliner, sitting, standing, all have effects on your breathing, and you'll find the different positions and recliner and the type of sitting that you'll find you'll breathe easier with. Airflow is really important. So a lot of my patients, I put a little picture in of a fan. So some of my patients get a battery operated fan and just fan their mouth when they go outside. This helps with their breathing. All right. So open window if you're home can also help fresh airflow. Anxiety is a tough one because shortness of breath can cause anxiety. So if there's breathing exercises you can do to sort of get yourself out of that. If you have a ventilator on the side, maybe one of those little 8-hour ones, you could actually just put that on quickly, and that, because my ventilators are all timed with breaths, so it forces breaths in when you should be breathing and stuff. So that corrects your breathing as its own. So some of my patients I convinced to take a ventilator home with them, even if they don't need it or don't want to use it. I just have it as a security blanket in case something like this happens, and they might just want to put it on for 20 minutes and just realign their breathing, give a boost to their system, and off they go. So and breathing exercises, I don't get too much into these, but there's other faculties that do this, and the breathing exercises, the benefits of that is managing mucus and reduce chest infections. So It also, like, didgeridoo, I've heard that really fixes your breathing up, but I'm not saying for you guys to start didgeridoo, but that's just an example. Then preventative measures, so influenza, pneumonia, COVID, vaccinations. The other one's eating small amounts. So a lot of people are still, they're still having massive meals. Once those massive meals start pushing up on the diaphragm and you've got weakness in there, you actually start having breathing problems after you eat. So one of my little moves there is, without a ventilator, you can start eating smaller amounts through the day. It's like maybe 5 little meals during the day, so you don't fill up your stomach and push up on the diaphragm and cause more, respiratory weakness or insufficiency. So I thought I'd just get into, so the research that I sort of follow is all basically ventilation type research. Our research isn't as it's not as enticing as other research, because my research is nothing about curing. It's more about just extending lifespans. So I know the goals there, stopping the disease progressing and all that, but this is what the research I sort of get into here is, how do I make the ventilation better? How can I expand lifespans if these guys want it? So this sort of started back in 1997 with the Abusin crew, and they found that patients that don't use a ventilator have a 3.1-fold greater rate chance of death. Right. So then we started getting on to stuff. So we're going, all right, these ventilators might be helping here. 2 years later, they found the Cleopa group did a retrospective observational study, and they found the ventilator improved survival and slowed the progression of pulmonary function decline. So the progression of pulmonary function decline, that fancy jargon there, means it stops. So with MND, your lung function gets decreased and worse. This thing slows that worsening, right? So it doesn't fix it, but it does slow it, which means it will prevent you going to respiratory failure quicker. So then we got the back group in 2002. Now they're starting to get a lot more data now, and now they're bringing out months and numbers. So they found 14 to 17-month improvement in survival in MND patients that use a ventilator. Over time, it's sort of decreased with more numbers, but then I've heard other studies saying it extends lifespan by 2 years. It all depends on that's first slide I showed you with all the subgroups. Okay, so some of those MNDs are a lot more aggressive than the others, and unfortunately my ventilator might not do too much significantly, but it will still keep you alive a little bit longer, no matter what. So then the Lechen group in 2007 found improved survival with early initiation of NIV. So NIV is the master machine. All right. So they found the earlier you get it on, the better. So that's where, and then in 2018, so there's been a lot of research in between that, but they showed that very early commencement on using a vent had a significant improvement in survival. And so this is one of the common questions. So we're starting to practice this a little bit with the neuro department. So our patients come in through neuro, and they get referred to respiratory and sleep pretty quickly now. So, and then sometimes I'm setting up patients where they're going, the neurologist said I don't need this yet, but why am I getting set up with it now? And this is sort of the background why we do this, because we find even if you use it for half an hour a day to start with, it gets you used to it. So if you do go into this respiratory failure, which I hope no one ever does, but unfortunately they do, it's not as scary. Like if someone says, "Oh, you need to put a ventilator on," you go, "Oh, I've got one already." Even though I haven't used it, but I've used it half an hour a day, watching Judge Judy or something like that. Just so it's one of my techniques. Half an hour of TV, just put the mask and machine on, and just get used to it that way. Because unfortunately, if you do go into this respiratory failure, you probably will come in and they'll put this ventilator on you for multiple days till that carbon dioxide level gets dragged back down. All right. And this is just one of my so this is one of my favorite graphs. So you got a scientist giving a talk at the moment. So usually you have a graph with a scientist talk. I apologize for that. But I feel, so this graph here is important as, so it's something in the population. So the percentage of all-cause deaths, so if it's a genetic disease like motor neuron disease is thought of, it should stay around that 0.10 or 0.1% mark or point. But what's happening over time is it's increasing percentage in the population. So something is triggering or reacting or making the MND come in quicker. There's something going on in the environment or externally speeding up the disease or making it more aggressive and making it more prominent. So some groups, like this is an Australian group, they've comparing cumulative petrol lead emissions, and that these guys have seen the graphs of the lead emissions going up the same rate as the MND deaths in percentage in the population. So these guys are guessing here that this may be the cause. So there's a lot of this sort of stuff out there where we need to you just got to be careful with saying, like, just because these two correlate on a graph doesn't necessarily mean that's why. Some of the other things, so this is an example. So smoking is a known risk factor. So smokers are known to have a more aggressive disease, and that's been proven in literature where the continuous exposure to certain substances, this is from that journal, especially heavy metals such as lead, also appear to be a risk factor. So that's the difference between known and appear. So these are all the stuff that we have to, with the research, I look at and I decipher. Also, one of the other things I found, which I can back up in clinic, is a higher rate of MND when compared to general populations, professional athletes and military. And so I've had some pretty good athletes in my clinic, more local, but yeah, and military. I don't deal with too much of the military, but yeah, there's definitely good cases out there saying there is. So that's just some of the references, but now it's time for questions if anyone has any.
Yes.
Sorry, I was
Thank
1 minute
you
late.
so much,
Or
Saul.
early.
No, you've done very, very well. We have questions, so
Good.
I'll open it up. But before we go to the questions, I'd really like to thank you. I've learned a few things as well myself, and I think I'll let some questions happen. So, Marie, you were going to ask a question?
Yes. I've got a ResMed Lumix.
Yep.
And I do have a battery backup for it.
Yes. Yep. So that's with the power station. Power station 2, I think.
I'm using a Medistrom actually.
Oh, yep. I've seen them online. Yeah.
So because if the power goes off while I'm asleep, it'll kick in automatically.
Yep. So I've started to drift away from those a little bit because of these more fancier ones. But yeah, I have had patients come with me exactly on your setup, but once it becomes 24 hours a day, I think it's getting a bit dangerous with those type of setups. But like, it's awesome to have that. Like, I reckon it's just because we're in public, our patients they don't really want to spend the extra $700-800 on a battery. They'd rather just wait for the next one,
Yes, but, I got my battery through my aged care. Through my package.
Yep.
Okay, so the only question I've got about it is I've got to go for a medical appointment on Monday.
Yep.
And if I'm in the car and happen to get a bit breathless, can I take that machine and use that battery?
Yep.
On the way if I have to.
Yep. Yep. No, that's perfect.
Okay, do I use the humidifier on it or not?
I probably wouldn't. So
no, okay.
Yeah, but if you don't have a cap, that's the problem, hey? So
the other question is the use of Ordine.
Push, pull, push, pull.
To reduce
breathing distress.
Yes.
Yeah.
So personally, I take a dose in the morning to get through showering and that.
Yep.
And basically that's it for the day, and then I just use my BiPAP at night.
Yeah.
So I'm not quite sure how long that will last for.
Yeah, it's all about how much hours per day. That's the key with you.
Yeah.
So,
Okay. All right.
and once you start using during the day, that's a big sign. Okay.
Yep.
So
Yep.
and once you're hitting 14 to 16 hours on that machine, you might be looking at overheating problems. And
Yep.
if you want to keep going with that setup, patients I have had in the past with that setup have two. So you'll need two Loomises, two batteries. Yep. And this couple had a lot of problems through the night. So one point it malfunctioned and they mucked around trying to get all the leads and all that for the second battery, and it was quite a scary episode for them. So, and because they were 24 hours, I swapped them over because it was quite hard for them to swap machines every day. And once I gave them that life support machine, they were in a lot better, you know. But with the government, you have to minimum. They like 16 hours per day proof of you needing this thing to get one of these like life support type things. Yeah. But if you can get it through different funds, like you may as well just go straight to that machine, you know. So.
Thanks, Marie. Now, Arnie, you do you have a question at all? Because I've got a couple people wanting questions. You need to unmute. Hang on, let me see if I can unmute you.
No, I've done it.
No, you've done it. Good.
Yeah. I've been on a CPAP machine for about 22 years.
Yep.
But I am noticing that I'm starting to get a bit short of breath. And I'm having trouble at the moment with phlegm and being able to cough it out because my breath is not as great as it used to be. I'm in Bundaberg, so I'm not sure how I source the ability to get professional help.
Yeah. So Bundaberg, like what you'd have to do is you'd almost go to a GP, refer to a public hospital, and see what services they have for you. Because I know Bundaberg's always a hard one. When I used to work at PA Hospital in Brisbane, I used to deal with Bundaberg patients, but now we got hospitals up the north of Queensland that are closer to you, like Cairns and Townsville-based hospital. Not sure, are they close to you at all, sir?
No, I'm closer to Brisbane than North Queensland.
Yeah, because the PA hospital has a very good service with couriers and telehealth and all that sort of stuff, but but you need to get to a sleep and respiratory. So who do you see for your CPAP?
My first sleep study was done at the PA. I had to go to Brisbane.
Yeah,
but the repeat ones have been done in Bundaberg by people who sell the equipment and have sleep. Yeah, well, they wired me up. The last one they wired me up and I slept at home. So
yeah, so they're pretty they're pretty useless for MND because what you need is carbon dioxide level measurements. All right, so because those things will tell you about your oxygen, but usually they don't have CO2 measurement. So that's why you come into the hospital, like the PA itself, and they'll wire up with a carbon dioxide measurement on you. And then that's what we look for, the trend in hyperventilation. But the way around that is an arterial blood gas as well. So if that nasty needle I was talking about where you draw blood from the artery, that will tell us what sort of state you're in at the moment in terms of your lung function and respiratory. CPAP's not going to cut it soon, unfortunately. You do need that ventilator with the two different pressures. So the way it works is with CPAP, you've just got one continuous flow of pressure and you're breathing against it. The ventilator has that continuous flow, but it detects when you breathe in and out because it's a lot trickier algorithm. Once you breathe in, it shoots this real high pressure into you and then it goes back down. And that mechanism of the ventilator is what drives your carbon dioxide levels down. On CPAP, you're not going to have that drive. It's just this. It's going to fix all your sleep apnea, but it's not going to fix your carbon dioxide levels and that hyperventilation I was talking about.
Yeah.
Okay. So it's a tricky one, though. But I think are you still connected to PA? Do you have a PA machine at all?
No.
So, because those suppliers aren't really like they're not in clinic with a doctor type thing. You're not part of their service, so to speak.
Yeah.
They get it. It's getting tricky, this business, because they are starting to do a lot of tests. They'll send your results to a doctor in another country. They'll report on it, and they'll just send it back to them and say, "Oh, this is what's wrong with you." But yeah, with it's usually good to have a hospital-based sleep study, or someone that can measure your carbon dioxide levels. But I think you need to get to at least a respiratory doctor, and not really muck around with these sleep joints. I think you need to go to see it, and we need some lung function tests and stuff. And it might be, if PA is the closest to you, I know that's going to be a really good hospital to go to for you, because they're brilliant at MND. That's where I did all my training. So I've been there since I was there in 2005, 2006, and I started dealing with MND from 2007 onwards, and it was an awesome training ground. But we did see Bundaberg patients, and it was very hard. We had to courier CPAP machines up to you and courier them back and stuff. But yeah, I think that would be your first step. Maybe go to GP and say, no, I need to be referred to a respiratory or sleep specialist, and see where the local one is, even if it's private. And then they might send you to the local. It's all postcode restricted now, these things. So even if you guys wanted to come see me, you could try, but it might get rejected due to postcode restrictions now. So yeah, so it's
my problem too with travelling is that I'm restricted to a wheelchair.
Yeah.
Which means I can't even get in their own car to travel that distance.
Yeah.
So that's a hurdle for me as well.
Yeah. Where I know it doesn't help you, but we do home visits in this hospital as well, which like people like yourself. I don't think PA are going to home visit you in Bundaberg, unfortunately.
No.
But yeah, so I think I think that's your first step. Try and see a respiratory or sleep specialist, and see what the GP can do for you. Or see if someone can telehealth you or something like that, and make the first step. But because if you get a respiratory doctor or a sleep doctor, they can organise an ABG, which is that needle, in your home, or you can go to your local place, or try and get that ABG done. The secretion management, it's all done by physios in the community.
Yeah.
So I'm currently, I'm trying to help someone else actually with a Bundaberg problem, actually with cough assist and stuff. But yeah, that's cough assist you need for the secretion management, which is run by physios.
Yeah. All right, thank you.
Thanks, Andy. So we have Jeanette who has a question as well, but because we're nearly running out of time, we might keep it. We'll let you ask your question,
I don't mind, Sandra.
Okay. You're wonderful, so
we can go over.
Thank you. Jeanette.
Just Janet, just ordinary
Janet. Sorry.
Hey, Janet.
How are you?
Good.
I'm asking this question. I have 53 years nursing background, so we don't sugarcoat anything.
Yep.
What I'm currently going to the Royal Brisbane Clinic.
Yep.
Dr. Henderson.
Yep.
What do you have any indication of what sort of respiratory services are available in Toowoomba, where I live? We haven't lived here that long, so we're not locals in the. I don't know the Health Queensland system very well, so I.
So Toowoomba's a problem with my MND patients. So unfortunately, one of my patients moved from there to Gold Coast, due to this.
Yes.
Yeah.
So, but I think the most local service for you would be the PA hospital again. We used to see a lot of Toowoomba patients, but still quite far away. There used to be a private respiratory doctor in Toowoomba. I just can't remember his name that well. With Scott Street Pharmacy, and I don't know. But yeah, that's it is an issue in Toowoomba. So one of my patients, he came and saw me in ED in Gold Coast, couldn't wait, so he decided to go back home, dropped into Toowoomba Hospital because he had problems with his cough assist and stuff, and they said, no, can't take it, we don't have any X-ray machines. So it's quite he unfortunately, that my trauma patient, Hallidan, I think, or something, used to come to me, you know, so and it was a problem because it was like a 45-minute hour drive to our ED, and that's how they had to get into me, through the ED, and then with the promise of them always moving the Gold Coast, so they're keeping the postcode type thing. But if you present to the ED of a hospital, they have to sort you out. Just getting to that ED.
Yeah, so we're outside acceptance to Gold Coast, aren't we?
Yeah.
Yeah. Oh, yeah. Yeah. I think so.
Yes.
Yeah, it's more of a.
I have clients that are up that way that do come into the PA. Again, it's every 3 months they set up an appointment, but they need to actually go to the PA.
Yeah.
I don't even go to see Dr. Henderson. I do it all online.
Yes.
Yep.
Okay.
That's who you need.
Yeah.
Yeah.
We got some good stuff in the chat as well. So Barbara says there's a subclinic at Bundaberg who have helped them with a BiPAP machine.
Yes.
So BiPAP's the talk. So BiPAP's NIV. I just don't use BiPAP because it's a proprietary limited name done by Philips Respironics. So it's like calling Android and iPhone if you get technical with me, but I know exactly what you mean with BiPAP. And they monitor as well. So I get a lot of Henderson's patients come here. So they start off with Henderson, do a lot of research and get a lot of stuff happening. But once they become unable to travel to Brisbane anymore, they get shoot to me down the Gold Coast. And I manage them down here. But it all depends if they live here. That's the key to it. Sunshine Coast have a MND clinic respiratory specialist. So I know those guys at Sunshine Coast. So I know the doctors there. So I've even trained a couple when I was at PA when they were trainees. So they're all very good. So Sunshine Coast is another tertiary hospital like myself with sleep scientists.
Which is wonderful. But as you said, Saul, it's a case of physically going, unfortunately, to the hospital to be assessed.
Yeah, and it's it's going to be an issue. It's not nice coming to an ED. I can't guarantee straight into a bed, all that sort of stuff. But yeah, if you like, some of my patients give me notice about coming to ED, and I can let other doctors know and the ED guys, and they're all ready for you, and that sometimes helps the transition. But yeah, so. The other thing that it'd be good to have a service. So something we do with our ventilators is we have a after hours line. So if you have a broken ventilator or something through the night, you can call someone like myself at home on my mobile, and I'll be able to talk you through some of the stuff. But unfortunately, that's only for the Gold Coast people, you know, who's in my service. Once you're in another service, I can't intervene with that service and change what they're doing or intervene in that way medico-legally. So I'd be legally in trouble if I started advising you if you're from another hospital. But, you know, I won't leave you hanging either, as long as I don't get sued.
Well, we might, because it's close to, well, it is time to close, but Saul, I've learnt a lot of stuff, like to me, the importance of quite a few things that you've said, the importance of doing that REM sleep study to actually have a look at lung capacity, and also the research that's behind it saying that having that intervention that can prolong somebody's life with MND as well. Yeah. So we're getting a few messages saying thank you very much.
Yeah, I think so.
I've had some people. So I'll actually stop the recording